It's all so exciting. It's going to happen.
Ladies and gentlemen, welcome to Vertical Accelerator. Please take a seat. And Matt, you have the catch box right there. Welcome, please have a seat in the front. Ladies and gentlemen, welcome to Vertical Accelerator and the end game. Let me just start by giving you a brief intro to where we are, and after that I will hand over to Matthew Holt, who will be moderating the session today. So Vertical Accelerator is a startup accelerator. In essence, we help small startup companies to go to market together with large corporations. And digital or healthcare digitalization provides a tremendous opportunity which many have not yet understood. And that's one of the reasons why we organized the Endgame today. And just to give you a brief intro, so we have the Twitter hashtags, VEndgame. Please tweet, send your questions, and you also find Vertical at VerticalVC on Twitter. Our event partners, so we have some great partners. First of all, Lääkäriliitto, the Doctors Association of Finland, and then Sonera, Sitra, and Samsung, and then also Nordic Healthcare Group, Aalto University, and Lääketieteen kandidaattiseura has been supporting us in putting this together. The live stream that you are watching at home, it's provided by Flick. So, next up, Matthew Holt, co-founder of Health 2.0. I would say a very interesting guy who's going to tell you more about what he does and more about healthcare digitalization. Matthew.
Thank you. All right, I am delighted and thrilled to be here in Finland. I am as I said here, the co-chair of Health 2.0. You can follow me at @BaltiBoy. And I was thinking very carefully today what I should wear. Because, you know, when you're on stage, it doesn't matter what you sound like, so long as you look really good, it's tremendously important. And the great news is I had a lot of help from Pekka in my dress choice today. So what was I thinking about when I was on the plane? I really wanted to be in Finland. And now I am in Finland. So here we go. Woo! This is actually my first day in Finland. I arrived at midnight last night. Okay. So, Health 2.0 is, you can follow us on Twitter at Health2Con. I'm BaltiBoy. And just to those of you who don't know, and many of you I know came to Santa Clara. We started our conference back in 2007. In fact, Steve Crime, my friend at the back, was one of the first presenters with Organized Wisdom, now a Startup Health, which has its own great announcement with ThinPro today. It's a pretty big conference now, a couple of thousand people focusing entirely on digital health. Lots and lots and lots of live product demos, sponsors, and exhibitors. We're also global now. We just finished last week in Japan. So this is emblematic. We are not the cause. We are a symptom of a global movement of digital healthcare. These are places in the world where we have chapters. Just as some examples of where our chapters are, you can find out at health2con.chapters. And here's a database that we have of all the technology, different companies in different parts of the world. We're trying to capture everybody. I know that we have several hundred companies in China we've missed because I was lectured about it by our Chinese colleagues the other day. So, across the globe, there are at least 100,000 plus people deeply involved in digital health. At least 4,000 companies, probably many more products. So we are now in a global movement. This is a little chart that we put up. This is not a map of the world. This is a map of the different types of technologies. On the right-hand side there, you see the Rebel Alliance of new provider technologies. On the left-hand side, you see the frontier of patient empowerment technologies. Up above them are the big empires. On the left-hand side, old world healthcare, still run on paper. On the right-hand side, the empire of enterprise health IT, which companies and technologies using the new world of technologies invented in this century are going to be slowly overcoming. Give me a sense of some of these companies in our database. About half are consumer-facing, about half are professional-facing, or are doing professional provider communication, and many of the others are doing data analytics using big data. And these types of activities are combining. You can further break it down. We break it down by 19 segments. There are different ways of doing it. And you can see there's a lot of different activities amongst actual products, not just companies, but there are many companies have more than one product in each segment. And we have a very large segment, things like self-management tools and trackers. I'm wearing the Withings watch. Many of you others are wearing those too. And then down at the bottom, a lot of companies working in that last category of decision support analytics. Across the globe, you're seeing a variety of companies. Now, these data aren't quite right, because I know we are still missing some data, but most of the activities in the US, and I'm going to talk about some different places, some different activities in different places, a decent amount of activity in Europe, and then you're starting to see slow growth in Asia and also in Latin America. This is where the companies are situated. So that implies something you all know, which is that most technology innovation is happening in the US. We're also seeing in the US some significant IPOs. Fitbit, obviously, is the biggest name here. IPO this year, now has a market cap of approaching 8 billion. But also other technology types, such as Teladoc in telehealth, or Evolent Health, which is supporting provider organizations to understand the new world, another technology company like that. But it's not just IPOs that we care about. There's also significant acquisitions on both the consumer side and the data side. Companies like Under Armour acquiring many companies, including MyFitnessPal. Its German competitor, Adidas, acquiring Runtastic from Austria. Companies like Qualcomm acquiring the French company Qualcomm Capsule, which does data integration between devices in the hospital the way that Qualcomm does it outside the hospital. And of course, our friends at IBM, who are buying virtually everything that moves in the healthcare sector and data analytics. Okay. Here's some data on annual funding. You can see that there are various people who follow this data. We do, Mercom, Rock Health, Startup Health. We all have slightly different numbers, but we all agree that the direction is going upwards. Venture funding across the globe is going up dramatically, and we forecast for this year it's actually going to exceed last year's, which is already a doubling of the year before. So a lot of innovation, a lot of activity. But the money is only part of the deal, right? A lot of what's going on is in terms of pilots and partnerships, and how do we get this stuff into the system? We do this, Health 2.0 works on this. We're working both with ONC, part of HHS, and New York City, Pilot Health Tech in New York City. Just to give you a sense, there on the far right is New York City, in case you didn't know where it was. But we're also doing this across the US. Here's a bunch of different partnerships that we have managed a process where ONC, the US government, is funding not only large hospitals like Boston Children's to work with Gecko Health, but also if you look down there in Texas, right at the bottom of the map, a tiny company called MyCare Communicator is working with a rural clinic called an MHP Salute. So you're seeing a lot of activity, and of course there are more than 30 projects in New York City alone. And this is just our work. There are many other players developing integrations in the US and elsewhere between established healthcare organizations and the small startups that need to get their need to get customers and need to get validation. So this is a very necessary function that we're bringing together, and there are many others doing this as well. So it's great to see. Okay, other players in this, drug companies, this is Bayer, Grant for Apps. They're now in Berlin, they are in Barcelona, and they're actually thinking about coming to Tokyo. So just one example of another large corporation trying to help develop with small corporations. And of course, Vertical itself is emblematic of that with all the support that Pekka has engendered. I want to announce this is a new announcement that is happening tomorrow morning officially in the engine room stage at Slush. I think at 11 o'clock. You'll see our new colleagues at IFC, which is part of the World Bank. They're announcing an entire program taking new technology companies initially from across the world. Anybody can apply for this. It's called Tech Emerge. You can find it at techemerge.org. I encourage you to apply. Again, free money to take your technology initially to India, but also later to other emerging markets. So that's something that we're working on with them. So that's something we're very excited on. So I want you to think about, for the way this works, an entire ecosystem of partnerships and pilots between small technology companies and large organizations, facilitated by a number of organizations, including Health 2.0, but also Startup Health and many others. All right, I want to end my remarks briefly with thinking about why does this place happen? Why does this technology impact happen in some places more than others? I was just in Japan. They're very concerned about their lack of innovation. There are some real hotspots, okay? First one, quite an obvious one. We know the nation of Israel is often called Startup Nation. There are significant companies like DB Motion and American Well that have basically come out of Israel. Here are 3 examples of companies that we've had at Health 2.0 very recently out of Israel. Trito, which is a tool for looking at personal examinations to attach to virtual visits. MediSafe, which is a very innovative company that won our traction contest last year and has since raised about $8 million in the compliance management stake. And Trito, which is a data analytics company that looks at text and produces information out of that about pharmaceutical side effects. It looks at all kinds of text that patients have put into the system. So just 3 examples of of a country that's sort of punching above its weight, partly because it's got such a great startup culture, great connection to universities, and great connections, of course, to medical centers in the US, because that close relationship between Israel and the US. So that's one reason why you might have so much innovation. Another country, one you're very familiar with, the one we're sitting in right now, Finland. I just picked 3 of the many Finnish companies that we've seen featured. Bedit in the consumer space. Now you can buy this in American department stores like Bed Bath & Beyond. Nuna, Yanni from Nuna will be on the stage with me and Steve on Thursday. Really innovative way to do artificial intelligence to capture information from cancer. And Nelly, who I don't know if she's here today, Nelly from Latimecan, I could always get her name wrong, from UApp. They have the deal with Jamie Oliver, and they're now in the 500 Startups program, which is a sort of micro-change app for Finns. And again, I think it's a combination of what have you got here. You have Nokia and all the people coming out of Nokia. You've also got, obviously, TechS, etc. You've got funding, and then you've got real focus and ambition. I think that's great. And of course, Vertical is now going to be a big part of that. And then finally, I want to say a little thing about whether we really need to get this stuff to people who really need it, not just across the developing world, but also in the developed world, but also in the developing world. Here's a charity that launched at Health 2.0, Healthy Villages, which is doing pretty simple stuff. It's giving old iPads and old Android phones to villages to health centers in Kenya, Haiti, and elsewhere. And it's helped really educate patients there, especially about the value of getting into a clinic and hospital for childbirth. And as you've seen, the infant mortality rate in some villages in Kenya fall dramatically. So really, simple digital health technology is saving lives. Here's someone's, this is out of New York City, Smart Vision Lab, but we're working in Haiti, again, turning a cell phone into a way that people can get eye exams very cheaply and easily. Same thing true with a company out of MIT at Boston, iNetra, creating a system whereby villages in India can not only get access to better eye exams and cheap glasses, but also can actually, they're setting up local health workers as entrepreneurs. They can sell this. And the final example, one, again, this company out of Israel, a CEO from New York, called Mobile ODT. This is for cervical cancer screening. Very commonly done in the third world, very ineffectively done. But again, this type of tool can be given to a mobile, a health worker, community health worker in Kenya or somewhere like that. She can do cervical cancer screenings and not only send the results, send the data off to be analyzed and get more accurate results. She can also take payment on this and become an entrepreneur, a fundable entrepreneur. So we're seeing tremendous changes and very valuable care done. Okay, let me very quickly wrap. Again, I'll show you who, I don't know, I'll tell that again. What we're doing next, we have a big conference called WinterTech coming up in January, in digital health investing in JP Morgan Week in San Francisco. We have a conference for developers and designers in Boston called HX Refactored in April the 56th in Boston. And then two more, one you should know about, Health 2.0 Europe is in Barcelona, May the 10th to the 12th. And then finally, we hope to see many of you back. This will be our 10th ever Health 2.0 coming up 2016, September the 25th to the 28th. We had, I think, 80 fins last time. Hopefully we can get 100. Love to see more of you. Okay, so with that, I'm going to wrap, and I'm going to get off the stage. And I'm going to introduce our next speaker. Edgar, are you ready to go? This is Edgar. I'm going to give you the clicker. This is Edgar van Zulen. I got that right. He is the head of Philips Health Suite Labs.
Something
Edgar,
like that.
take it away.
Thank you. Thank you all for being here. Thanks. When I was on the plane this morning, I didn't have that much enthusiasm to wear a t-shirt like that, but I was very much looking forward to it, and for two particular reasons. First of all, what's being done here in this room and what we're all talking about in terms of startups, innovation and creativity is something that's very relevant to me as an individual, but I think also something that's close to Philips, and I think also that's something that we as an economy, as a world need. And I think the second thing that made me very enthusiastic to be here is that I always get inspired by people who have great ideas. And I might disagree with them, but I always get inspiration. And so before I even start my presentation, I already had like 5 other topics I wanted to talk about in my presentation, which unfortunately I cannot, so maybe we'll save that for next time. But I'm going to talk about the kind of like the digitalization of healthcare, but mainly what does that mean? It's great if we talk about an app or we talk about new tools, but something needs to change in healthcare. And I think most of us are aware of the challenges in healthcare. I think that's why most of us are working in this area. I think, do these numbers look familiar? Give or take 1 or 2, right? I think this is basically where the mission and vision of Philips is built upon, where we see there's a growing need for care. Care to young people, care for elderly people, but basically if we look at all the trends, and depending on which numbers we're looking at, which reports we're looking at, they can be off a few percent to the left or to the right. But one thing is for sure, the number of people who need care will grow exponentially in the coming years. The cost of that will grow even faster than they're doing today. Which ultimately means healthcare as how we know it today is not affordable anymore. So if nothing will change, the whole world will become a third world country because nobody can afford healthcare. And of course, that's not what we want. What we want is to offer healthcare, or at least I would say healthy living and healthy life, to all of the people that live on this globe. If it is for the young people with a chronic illness, as a diabetic, or if it's for the elderly people, which is a population that's largely growing. I read a UN report a few weeks ago. I think in 2050, I think the total number of inhabitants on Earth will be about 9 billion people. If you just take 30% of that, that's a lot of elderly people. And if you then calculate the number of people who have 1 or more chronic conditions of that 3 billion, That's a lot. That's really a lot. So something needs to change. And I can already give away the hint. Philips does not have the total answer. We will not solve that by ourselves. That's why I think initiatives like Vertical, I think, are very good. I think for us, how we look at the world is we say the healthcare is transforming from episodic interventions to continuous care. From fragmented, you go to your general practitioner or you go to the emergency room in the hospital, which are not connected. It will be more connected. Not only because technology allows it, because we need to connect it, because there's a lot of inefficiency in there. And last but not least, today, most general practitioners or physicians get paid on, how I call it, effort. The number of patients they see. Yeah, I think for them, those numbers in the current way of thinking might be good, right? More patients means a bigger market, means more money. But in the end, if nobody can afford it anymore, then your market share will drop anyway. So for us, these are the 3 key drivers that drive the strategy that we have as Philips, to say we believe in continuous care. It needs to be connected, already from a healthy person's perspective to when, and I hope it forbids, when something happens to you. And last but not least, it will be more on quality, on value. So what we say, a new perspective is needed. And this is an illustration, and some of you are familiar with Philips might have seen a variation of this one. We call it the health continuum. And this is the new org chart of Philips. Basically what we say, our organization will focus on the health continuum. Our products, our services, our engagements will be around, call it the life cycle of a human being. If you look at today's healthcare, and we call it health care, taking care of health, most of the time when I'm in touch with my doctor or when I go to the hospital, something's wrong with me. It's kind of like disease care. So I would like to go from disease care more to health care. So if you want to go for health care, you need to go a little bit in front of the process. To say, okay, if you're healthy, what can I already learn from myself if I'm healthy? How can I even prevent becoming sick? Or maybe when I'm sick, when I have a chronic disease, which, in some cases you just can't control, diabetes type 1. But you can learn to live with it, that it won't become acute, that you need to go to a hospital. It's how you deal with it. So basically we go from healthy living, from brushing your teeth, eating healthy stuff, moving. Everybody has like the Fitbit trackers or the Apple Watch, anything, whatever, it tracks your sleep, which is all great. And I'll come back to that in a minute. From preventing like a diabetic to get like a hypo where his blood sugar all of a sudden drops, and he or she might even become unconscious. So something goes wrong, you go to the doctor and he or she, they do a diagnosis on you. And that diagnosis, in most Western countries, and I should be very careful by articulating this, most Western countries, it's about a 48% on average, and I think it was about 80% of the EU countries. I think the exact number I don't have with me. But 48% of the diagnoses done are incorrect. So kind of like 1 out of 2. Well, sometimes it gets fixed like 10 minutes after the fact, but sometimes it takes a few months. So if it's about a few months that it will take, it's all the cost that it will incur in the wrong process. Or even worse, somebody gets the wrong treatment and might not even survive. Or gets even more sick. So for us, if you get to the diagnosis phase, we already want to know something about you. And of course, then we know better how to treat you. And then once you have been treated, we want you to send you home as soon as possible. And everything needs to be done. We believe that should be done with kind of like informatics. Call it big data, call it algorithms, call it an application. Make it very simple. We want to connect it all. Literally from a toothbrush that can sense how healthy your gum is, because the healthier my gum is, the less influence it has on cardiovascular diseases. The better I eat, the more healthier I eat. I watch my calories, I watch my vitamins, I watch my intake on salt. I avoid high blood pressure. You don't want that. But in some cases, I like to eat a lot. I like to cook as well. Good thing is I also like to exercise a lot, which keeps it in balance. And I don't register today what I eat. but I did it for a month once, and if I then watch what I ate actually, and I like to go to restaurants quite often, I eat a lot of salt and a lot of fat, butter, which is not really healthy for me as an individual. So basically by writing that down, which took a lot of effort for me today, made me more conscious in the way I eat and what I order in a restaurant. I still enjoy it, but in a different way, more conscious. And I think that's also part of it. What we do as Philips is we want to look at the total health continuum. Call it an end-to-end process, call it the life cycle of a human being. But in order to illustrate that we as Philips believe that the world is changing, that we as a company need to change from selling an MR scanner or a PET CT scanner or, I don't know, an ironing or a toothbrush, we really want to provide solutions that matter. And for that I have a short movie to introduce you, Ralph and Helen. And they both have been married to each other for 64 years.
I like Sun City. It's a nice community. Our grandchildren come over here once a week. We have a couple of good friends that we like very much.
In our age group, these are the things that are important.
When we first met, he was just a friend, nothing serious. He took me to a football game and gave me my first kiss.
Don't go overboard now.
Without communication, Ralph and I could have never survived the 64 years.
We know that the top 5% of patients in any system use a lot of resources, time, money, people, you name it. Philips and Banner are partnering to take care of the sickest of the ambulatory patients. We hope that we will be able to provide the support that they need to allow them to continue to live out their days at home.
Ralph's not very good at taking his own blood pressure, so I take his blood pressure every morning. But he gets on the scale, weighs himself.
184.4 pounds.
And then he goes to his little video. I'll learn to say tablet one of these days. At first, we were a little hesitant about all of this equipment, but as it was explained to us by people from Banner Eye Care and from Philips, we reached a point where we felt comfortable with it. Today, I would be lost without it. I'm just happy to be home with Ralph. To be able to talk to a doctor on a video, and we don't have to wait 2 or 3 days for a doctor appointment. It's fabulous. If I have an emergency, all I do is push a button. There's somebody at Banner Eye Care there for me immediately.
This is the future. It's really an amazing model of care that doesn't exist anywhere else yet. When I have a team of people augmented by a lot of Philips technology, I can catch things earlier, treat things earlier, and intervene in a way that allows me to accomplish what I set out to do as a geriatrician and then ultimately do some good in these patients' lives.
I will skip this till here. This is a video we made, I think it was in 2014. And I'm very happy to say that there's many more initiatives right now going on. I even believe, I think in Finland, the city of Oulu, help me out, what is it? What I like about it, there's a lot of great initiatives going on. But what the challenge is with those initiatives, how do you scale those initiatives to really make them on a nationwide? Because it's not just the technology, because that's already available. What we did here, we teamed up with a hospital, and it's kind of like a hospital network with physicians, with kind of like they built their own patient monitoring center in there. We provided them with algorithms, with software, with tablets, with connected devices, all early stage, and we created an integrated care model. And just to do a test with them. And this test resulted in the fact, just for Banner, we said there were 38% less hospital visits And there was 67 less emergency department visits for the patients who joined the program. And of course, numbers will change, be different for each hospital network or even each country. But I think for this particular example, it saved them about $10,000 per patient per year. Just for that. And 10.2 days per year, which results in $27,000 per year per patient. So think about scaling that in terms of saving money. And I think that for us is where we as Philips would like to go to. We are today building a platform called HealthSuite Digital Platform. This is a platform which will be open, has an open API, which will have a lot of algorithms from Philips, which will be connected to our MRIs, where we will connect them to all of the data points we have. We have, let me go to, so from the intensive care units, from all of our scanners, where we already do a lot of algorithms. But today, those algorithms are in the systems, and I always call them legacy systems. And I should not say it with colleagues in the room, they get very upset when I say that. But it just takes, within the next 5 years, these applications will be in our cloud, which we are building today. And they realize that, and they like it, because they can see the power of that. Because one of the examples on the top right, for example, is digital pathology. Just something very, very simple, I would say. Normally you work with tissue to see if somebody has cancer. It's very physical. Now it's just non-invasive. So it's literally make a picture. And with that, it identifies all the cell structures and you can share it. And already on the top left, they can have a real-time conversation with a doctor somewhere else. So you can have a second opinion on the spot. Something small, which improves the speed of diagnosis, which even improves the accuracy of doing a diagnosis, because the barrier to do that and get a second opinion is much less. And I think for us is also at the home. And of course we keep talking a lot about the smartwatches or the apps on our phone, but one of the pictures I just skipped is most of the times we have all those application devices and we call it the Internet of Things. I always refer to it as the Internet of Things, because I almost have a different app for each of the applications and devices that I have. Not all are integrated in one nice dashboard, which brings me the context that I need. Because for me, a heart rate could be something different from my mother, who is 72 and is a heart patient and has an artificial valve. And also an ICD in there, which every, 2 or 3 times a year, she gets like this little shock to kind of like resets her heart, which she doesn't like, but I like, because that basically tells that technology worked and that she's still alive. But her heart rate it has a different context than mine. So you combine all that data together in a platform where you're able to deliver that. So basically, if you look at today, there's some staggering numbers we as Philips already do today. We have access to a lot of consumers. We have access to a lot of clinical environments, from hospitals to general practitioners. But the thing is we want to connect it all. It's not about these numbers. It's great to have, I'm always impressed with 24 petabytes. Somebody told me last May that we uploaded 16 petabytes already to Amazon, which made us kind of like the 3rd biggest customer instantly. So just realize how much a petabyte is and then upload it. But then if you have you can do the analytics on all of those images and history, different modalities. Combine it with contextual information. Combine it with the wide information from people living in their home. That would be kind of like interesting in terms of your decision support systems. Think about those algorithms that are needed. So if you think about a digital transformation, it's not just about the technology. It's about how you make it work in the healthcare system. And that's the challenge that we have as Philips. And HealthSuite Labs is an initiative that I'm very lucky to lead, to set up. And the question that I got was the size of an A4, kind of like empty. We call it HealthSuite Labs, and at Edgar, we need a new way how we engage with our customers. Because at this point in time, we don't even know, in some cases, who are our customers. Because in the past, we would sell an MRI scanner to a radiologist. But if we look today, as the example of Ralph and Helen, are Ralph and Helen then now our customers? Are they the customers of Banner in this example? Or is then their physician our customer? Or is it the hospital network our customer. So you have kind of like the healthcare system, you have people in personal life. It's kind of like our salespeople get a bit schizophrenic, and also our customers don't know who to call anymore, and they want it, but nobody gets it organized. And what we want is to get it organized with Health Suite Labs in a way where we co-create and co-innovate with our customers. We do things together. And no, somebody made the comment before, we are not competing with vertical, we embrace initiatives like vertical, because we want to partner, co-create with other creative people who have the brains to come up with ideas that we as Philips cannot do. So basically what we want to do, we want to accelerate the decision-making process of our customers and the innovation. That's not focusing just on the technology. In those sessions that we have, and those processes we have with them is basically from a patient to a general practitioner to a radiologist to a managing director of a hospital, people from research from Philips, people from design who normally think about consumer journeys, now think about patient journeys, get technology people in to really start rapid prototyping on the spot when we think about a new care flow. That's what we do. And although Matthew said I have 1 minute left, I'm going to steal 2 more minutes because I want to close off with this little video that gives you a piece of energy of what Health Suite Labs is when we opened our first co-creation center.
This is Philips Health Suite Labs Co-Creation Center at the high-tech campus in the Netherlands. The Health Suite Labs environment spurs healthcare innovation from vision to rapid prototype development. We bring together a team of healthcare directors, care providers and patients, along with Philips clinical, research, design and digital experts.
Today we have worked with a group of people from our regional care networks in the Netherlands, in Tilburg, which is in the south of the Netherlands. We've involved many stakeholders around the patient, in this case the diabetes patient, ranging from the hospital, the primary care, general practitioner, the intensivist and a couple of other care providers around the patient.
Het nut om samen met andere partijen in de zorg na te denken over de verbeteringen in de zorg is met name erop gericht omdat je het alleen niet kan. Alleen als zorgverlener ben je een te kleine speler in de markt en je kan je ook niet verwachten dat je zorg kan veranderen. En dat zul je met wereldwijde spelers op moeten pakken.
Ik vind het heel belangrijk dat alle partijen met elkaar praten. Willen we tot een goed einddoel komen natuurlijk. En daar heb je niet alleen de patiënten voor nodig, maar dus ook de internisten, de diëtisten, noem maar op, iedereen die met diabetes omgaat en voor werkt.
Wat ik belangrijk vond, vooral van de eerste visiedag, was dat iedereen samen kon zeggen hoe het eruit zou moeten zien. Dus dat de neuzen allemaal dezelfde kant op staan.
Ik ben erg onder de indruk van de mensen van Philips, hun deskundigheid daarin in die procesbegeleiding, maar ook in het zorgproces zelf. En ja, nu zijn de techneuten aan de beurt, de ontwerpers en de mensen van design. Ja, en die maken zo fantastisch mooie dingen. Daar wordt iedereen enthousiast van, want nu zien we ook echt het resultaat. Wij hopen dat Health Suite Labs kan bijdragen aan de koppeling tussen gegevens die professionals verzamelen over de patiënt en hetgene wat patiënten zelf verzamelen. En dat daar een goede uitwisseling tussen mogelijk wordt, zodat patiënten beter in staat zijn hun ziekte, maar ook hun gezondheid goed te beheren.
Wat mij is opgevallen in deze Health Suite Labs en in deze samenwerking met de verschillende partijen, is dat door dit op deze manier aan te pakken, dat we veel meer kunnen bereiken in een veel kortere termijn en veel sneller kunnen handelen.
Wij denken dat het belangrijk is voor de patiënt, omdat wij ervaren dat patiënten last hebben van de schotten in de zorg. Nou, als zorgnetwerk zijn we al hard bezig om die schotten te slechten. En we vinden in Philips een partij met dezelfde visie en dat is heel plezierig.
That was it. Thank you.
Nice job, Edgar.
Sorry for being late.
All right, hey, no problem. We just didn't get the chance to throw the box around. But anyway, okay, next up, we're going to shift a little bit from the world of thinking about ecosystems to more talking about some application tools. Okay, next up is eco-economo. Name even close to right, from Duodecim, which is part of the overall Finnish Medical Society. He's going to talk, the title is Dr. 2030, a life coach or a robot. But really what he's going to talk about is the role, the emerging role in the future of how electronic medical records are changing and the role in the future of care, decision support, and care pathways. So please take it away. Grab the clicker for me.
Okay, thank you very much for inviting me. I'm a medical doctor, a clinical decision support developer, and I will give an overview how digital health can be implemented by the integration of data and knowledge. Let me first introduce you two people. One is Anne, and the other is Tim. Anne is 35 years, and Tim is 55 years. They don't know each other. They have only one thing in common. Both have a cholesterol level of 6.8, which is moderately high, according to our reference values. So the clinician meeting these two people might think, what's the evidence for treating high cholesterol with a statin? That's a drug that is commonly prescribed for high cholesterol. So let's see. If we look at the evidence, we read the systematic reviews, so we find that irrespective of the age of the patient or any underlying risk, the relative effect of a statin means that there is about 25% reduction of risk for stroke, myocardial infarction, or death. So how about, would you treat both of these people with a statin? Of course, we need to look at the absolute risk for any of those events. And there we need some more data. Actually, we can use about 9 risk factors to estimate the risk of such an event. If we first look at Anne, we see that actually all the risk factor levels are very low, and her risk is 0.7% in 10 years. That means that fewer than 1 out of 140 people like Anne would get any of those events, stroke or infarction, in the next 10 years. And that would mean that if we would give statins to people like Anne, we would need to give the drug to 600 people to make one of them avoid such an event. So we say that the number needed to treat is 600. Okay, let's look at Tim. Tim's risk is 61%. He has many risk factors: high blood pressure, diabetes, he's a smoker, overweight, and so on. More than 1 out of 2 people like Tim would develop an event in 10 years. And that means that only 6 people like Tim need to be treated with a statin to benefit. So that means that the number needed to treat is 6. And that's actually a very good effect for any healthcare intervention. So, what healthcare is about? Steven Spielberg told that us in year 2000 in the movie Minority Report. Those who saw this movie know that Tom Cruise prevented crimes by predicting a crime, then intervening very quickly and prevented the crime before it was committed. That's all about healthcare. We want to predict and we want to prevent. And that can take place if we combine data and knowledge. Today, patient data is in silos. It's in electronic health records, personal health records, even glucometers, other devices, and those vendors are jealous. They don't want to share the data with anyone. The data is in silos. The first condition to make digital health work is to put the data in one place. Data recorded by healthcare professionals, data recorded by patients by themselves. The majority of data will be recorded by patients by themselves in the future, specifically when they have devices and wearables that record everything. Now it's called body hacking, but it will be the mainstream in the future. So it will dramatically change the picture. Now, the data is available for everybody, and all EHRs and PHRs, they will become apps that can store the data, that can use the data from this common data store. And even every mobile phone app for a single purpose can do the same. The world will be full of health apps. And how to integrate them with the data. There is a very interesting, I would say, hot standard called FHIR, which has already been implemented by many companies. You can go to this App Gallery webpage, and you can see how nicely patient data can be visualized by these tools. And not only visualized, but connected and integrated with knowledge. Here is a little bit the bigger picture. On the left side, you have data of the individual patient, but you also have history data of all patients. You have big data. On the right side, you have all medical knowledge from different sources. An ideal situation would be that there would be one interface to the data and one interface to the knowledge. And then there would be a secure gateway where you can exchange the data. And all the apps could connect to this gateway. Actually, this has already happened in Estonia and will happen in Finland, where we have what we call an X-road. And also, Finland and Estonia, they have a national archive where all patient record data is stored. And also PHR data will be there. This is one example how to integrate data knowledge on one screen. Here we can see the diagnosis of the patient, the medications, relevant lab test results. For the diagnosis, which we have clicked on the left, we can see decision support reminders for that diagnosis and guideline links for that diagnosis. If we click another diagnosis, the whole view will change. Now it will show the data for that diagnosis and also the knowledge. This is such a simple modeling study where 4 minutes were saved at each patient encounter by using such a tool, and 57 mouse clicks were avoided. There is another example, the comprehensive medication review, all guidance on drug therapy and medication safety on one page for the individual patient, just by combining all the data and all the knowledge we have on drugs. So, today, on the right side, we have about 100,000 different data elements. If we sum up all diagnoses, all drugs, all procedures, all lab tests, that makes about 100,000. In the future, we will have millions or even billions when we have the genome data, we have the protein data, we have the gene expressions. So the amount of data from the individual patient will explode. But so will knowledge. Currently, we have about 25 million citations in the PubMed database. Year 2012, for the first time, the number of new medical publications exceeded 1 million in the year. And even more, if you look at the genome data, the explosion started when the human genome was sequenced. And after that, the doubling rate of genome data has been about 18 months. Not only about humans, but all other organisms like bacteria, parasites, also their DNA has been analyzed. So, genome data might already be important for Anne or Tim. Here is a study which used the data from all cholesterol trials in the past. And the genome of many of the participants was analyzed, and then the genetic risk was determined. And we can see that those red columns are is the benefit of statins for people with high genetic risk, and the green bars is the benefit for patients with low genetic risk. And note that all the other risk factors were the same for these people. So you can imagine that for people like Anne or Tim, this might make a difference if you knew their genome. We need some special tools. We need, in the middle, a database of validated gene associations, which knows, for instance, how the different combination of genes lower or increase cardiovascular risk, how they modify the effect of drugs, or how they determine some conditions. And on the left side, we need a query interface to pose a clinical question. It's no use of giving the clinician 40,000 lab test results. That means all the genes of the patient. We need to make a query to these gene associations when we have a clinical question where we need that information. And that's what we can do with a clinical decision support system, which you can see on the left. So now let's start building a big picture. The patient in the middle is recording data, professionals are recording data, and we will have coded data in the database. We analyze the data with clinical decision support tools. We identify potential for health benefit that consists of individual interventions we can do for the patient. We did this in Finland for a population of 16,000 people using 100 clinical decision support rules, and we found 400 people whose blood pressure should be treated. We found 58 people who haven't visited at all for their diabetes. We found more than 1,000 people whose drug dosing should be checked because they had renal dysfunction. And we found 28 people whose drug should be stopped because they had severe renal dysfunction. So we can identify the benefits, and we want to make a care plan. And at this stage, actually, we would like to know the amount of benefit, the balance of risks, balance of benefits and harms we get from each treatment before we can make a treatment plan. And this is how medical knowledge is and will be organized. This is called a summary of findings table. In the middle, it describes how many people out of 100 would get an event, or for instance, in this case, would be helped by a drug, would be helped without a drug in a certain time period. On the right side, you can see how many people would get the benefit if they would be using the drug. Now, when we want personalized and individualized care, we want to estimate the baseline risk for the individual. What's the likelihood of Tim benefiting from this drug? This is personalized medicine when we can estimate the baseline risk. So once we do that, we can also tell the benefits and risks to the patient, and then the patient can decide which are the important outcomes he or she wants to pursue, which are the targets he or she wants to meet, and which are the interventions he or she wants. These are the important choices that the patient has to make. And once they do it, then we can prioritize. The population can be listed and sorted by care benefit. We can analyze the care gap in the whole population. For each patient, we can put the most effective interventions on top. And finally, people choose from those interventions which they want to implement. So, from the society viewpoint, there are high-impact interventions where the outcome is important, a prevalent condition, the net benefit is large, and the care gap is large. These are the points where we should pay attention to, and these are the patients we should care for. High-value intervention, a cost-effective intervention, is something where also the cost per quality is low, so that we can obtain a lot of benefit with rather cheap interventions. So, the whole medical knowledge needs to be reorganized. And this is happening by organizations and companies, which actually all healthcare companies should communicate with to get the evidence in place. Here are just examples. There are many other such companies and organizations. This is just one example. The PICO is the element of the clinical question: patient group, intervention, comparator, and outcome. And there is a PICO ontology developed by the Cochrane collaboration, which will actually organize all research results in this way. So, finally, We can make the care plan, and when it's coded, we can automatically provide tools for the patients for self-management. They can make an online health check, and they can receive online health coaching for their problems. Maybe Tim didn't want a cholesterol drug at all. He wanted to make a lifestyle change and opted for that. So, but there are situations where we also need the professionals on the right side. And then we need some tools to make the professionals work effectively. We saw that we can use clinical decision support for care planning of one patient. We need enterprise resource planning software for planning the care of the whole population. Here is a care plan for an individual patient. It has some time points. It's based on evidence. It has been agreed by the patient and the clinician. If the patient has many conditions, there will be many things he has to do. So we need to coordinate. We need to merge the encounters to a care plan, a coordinated care plan for the individual. And once we have those coordinated care plans for every individual and every service there is coded, so then we can feed those services and codes to the resource planning software, which puts all these things nicely in the workflow of the clinicians, and all the bookings of the resources are made automatically. So you can see that at the bottom there is an arrow from resources to the care plan, that the resources are taken into account when the care plan is made. On the right side, there is the big data that is gathered all the time that will also influence the future decisions. So we will be able to build a learning healthcare system where every data item in the electronic health record contributes to the body of medical knowledge, and where every series of actions in the electronic health record is actually recorded and analyzed to understand workflows and to find shortcuts. So finally, we can obtain health for all. It's a political choice for the society, but it's a question of values and preferences for the individual, enabled by digitalization of healthcare via integration of data and knowledge. Thank you.
Great, Ika, that was an amazingly complex, simple description of something that's amazingly complex, and we call that in the States the Learning Health Society. So we're hoping to have time for some Q&A after we get back on track with the next couple of presentations. I do have the catch box, which is the microphone we'll send around. But next up, it's Niklas Sundler. Niklas is the head of Telia Healthcare. Grab the tool there. We'll get Niklas a chance. And we're going to move from the complexities of workflow planning across the healthcare system to what's going on, more important perhaps than inside the healthcare system, but outside in real life, and Telia's solution for that. So Niklas, please take it away.
Thanks. Is the mic on? Yes. Niklas Sundler. I started at Telia, which are the Swedish part of Telia Sonera, 2 years ago. Before that, I was the IT director for one of the country councils in Sweden, responsible for the healthcare systems and the IT environment. We had an environment with over 800 IT systems, with patients, with more than 500 systems, the patient's data. The average time for each employed people, over 30,000, was to spend 92 hours to copy information from one system to another system. And if you have that in a background, it's very interesting to understand which kind of change and which kind of force we are actually providing with the digitalization within the healthcare sector. Today also our Finnish side, Sonera, is also starting up their vertical around the healthcare part, and I'm trying to support them from the Swedish side also here too. So. If you look into the big picture, I guess that more of you have seen it. It's not just a change in the way that the society works, it's also a change in the kind of diseases, the amount of elder people, the way of how we work with diseases from a wellness perspective, and so on. So there are many different changes in the air at the same time. If you just look into the Swedish society, we could see that if we look approximately 20 to 30 years ahead, we could see that we will need to go up a little more than 13% on the tax, just to cover the cost if we should keep on working the same way that we do today. And if you look into the different kind of politicians and the way that they are discussing about it, you can see that they're not really discussing this question. Everyone knows it, and everyone knows that if we don't do, and if we don't take the next step in the digitalization, we probably have a huge challenge in how we should get the money to cover all the costs that we will have, and to handle the right kind of level of support and the way that they're used to in the society. And if you look into many other Europe's countries, you will see the same picture. And we heard some of the previous speakers here too, touching that subject too. But they're not just the change in the society and the way of how we should build the system and how we should support the digitalization. It's also about the patients. So what we can see also is that one of the important change is the way that you will need to get your support. So what we can see here is, this is some slides from patients like me. I guess the most of you have heard about them. They started up in the 2006, I think. And there is a kind of social network where you share your patient's data. And you do it in the purpose of getting in contact with other persons that are in the same situation as you. And by that, of course, we get a lot of knowledge and information. And in the beginning, it started up as a threat. Today, I guess that most of us see it as a huge information source and a huge possibility of how to change the way that we provide healthcare, but also the way how we should develop the next step of the medicines and the support. But from a patient perspective, it's all about them. It's all about putting them in the center and giving them the possibility and the tools to get the information, what works for another patient, what won't work, and what should I avoid, and which kind of doctor should I meet, and which kind of doctor should I don't meet. Which kind of doctor should I go to if I would like to have a special kind of treatment. So there is a lot of force and a lot of power in the change of the patients getting in the center. And of course, we all know and we all can see a lot about the different kind of sensors out there today. And a lot of us is involved in putting up new sensors and new ecosystems around sensors into the market today. And but when we talk to the healthcare sector, we talk to the municipalities or country councils that we have around, they are not clear about, is this a support or is it a threat? The change in the way of having wellness sensors or different kind of activities that are not controlled by the healthcare system. At least in Sweden, there is a lot of discussions, especially if you talk to the doctors and the doctor society around it. I would say that you have more than 50% of the doctors are saying that no way we will trust information that will come from the wellness sensors or the not medical devices provided by the healthcare system. But the change is there, and the move is pretty fast. So from my point of view, they don't have an option. But what we need to do is that when we do the change, we need to do it step by step. And we need to find a way where the doctor can choose to see the information or not to see the information. And because what we know is that the doctor is still the responsible actor for the decision made to the patient. At least the decisions that the doctors are involved in. So when we see the different sensors around there, we see the information, you can have them to support yourself, but it's not clear that you can have them to support the healthcare or the health provided by the hospitals today. At least not if you listen to the doctors. But of course, there are some doctors that are into the way now and looking into how can we actually start to work around this system. And I will get back to that shortly in the next couple of slides. So when we look into the patients and the relatives to them, and we are seeing what are their picture of which kind of life would I like to have. I had a long discussion a couple of years ago with Bernard Tyson, who is the CEO of Kaiser Permanente. Actually, on the same day, he got the announcement that he should be the CEO. We had in Almedalen a politician event in Sweden as a speaker. And he said that the patients are coming to me. And their view is that I pay you, since they are an American company providing me healthcare. And he said that they're saying to me, just fix me. I'm paying you, and if I should keep on paying you as a hospital and an insurance company for that, then you have a responsibility to fix me. Because I would like to have this life, the whole life in this kind of way. So in some kind of way, there must be a balance in how can we get the forces, and how can companies like Kaiser Permanente support their customers and their patients in getting up the right kind of view to the future, and making sure that when they get older, they are not in a hospital or in an elder care center. They are staying at their home, hopefully having a nice evening. It's the same kind of situation as we saw on the movie before from Philips. And I guess that this is the reason why we are sitting here. And this is the reason why there's so much discussions about the healthcare. We need to give a completely new situation, and the way that you as a person is looking into what kind of demands do you have, and how do you like to spend your future. Everyone, I guess even me, I don't have it's not a hard choice to say which way should I sit in or which way should I work for. So when we start to work around and we start to look into how can we support it, initiatives like this one, vertical, and initiatives like Health 2.0 and so on are very important to do the change. And but the ecosystem around will look completely different. So if you look into that, the patients today will not just be monitored by the doctor. It will be probably monitored by themselves. They will need to find services and ways to get the support around them in a completely different way. And the ecosystem will look completely different. We can see a lot of pharmacists discussing about how they will support the patient and having the contacts with them. We can see in Sweden we have something called kvalitetsregister, quality databases, which are used to store a lot of information about one kind of illness and sickness, and they are by that trying to process the data to actually understand how they should treat the patients in a better way. But they are now starting to look into how should they interact directly with the patients. Should they take a different role or not in the ecosystem? We have the patients organization. We can see quite a lot of them are now not discussing how they should try to work for the hospital to change the way of working with the patients. They are looking into how should we support the patients? What kind of systems can we have in place? How can we interact in a different kind of way? And if you look into patients like me, there are a lot of discussions about patients like me 3.0 or whatever kind of discussions around it. And of course, there are actors like Telia Sonera or Telia. Sonera is trying to work, how can we support too? And how can we store and help with all the values and the communication part that will be out there. And I mean, if you look into more and more of this is happening outside the hospital, of course, which are one of the questions that we're looking for. And but today we can see that the patient and the doctors often meets at the hospital tomorrow the patients will be outside and the doctor at the hospital, and the day after that probably the patients will be at the hospital and the doctor will be outside. And they need to find a different kind of way of doing the communication. But I think that the ecosystem, and I would guess I probably missed a couple of them, looking into this ecosystem will change. And there will be a lot of other organizations and other parts around. If you look into, this is a picture from Eric Topol, one doctor in the state. I guess some of you have seen it. But from my point of view, the interesting area is the area that you see down here. It's a change where you change from diagnose up to manage your sickness, to predict and prevent. And when you start to work in that direction, as we heard a couple of other persons around here, we started to have a discussion, how can we avoid someone being a risk of having diabetes type 2, for example? Not just monitoring your health, but also looking into the society. We know that if you live in this area in Sweden, you have this distance to a fast food place, you have this income, and so on, then you have a 95% risk of having diabetes type 2. So what should we do? Should we start to move the fast food places? Should we change the salaries around? Or how should we change the ecosystem to actually take away the risk? In some kind of way, it's about picking the right person and giving the right kind of support. This is another picture from Eric Topol too, about his view of it over his patients. Which kind of patients are the patients that needs the support to be able to handle in the right kind of way? I think I have a little short of time. This was Jan Nosta, who was another person that we had in Almedalen this summer. He's talked about Star Trek and the way that you scanned yourself. And he said that the next version of this looks like this. And you can buy at least one of them today, and there are several coming up too, that will scan you and give you a lot of information about the situation. So when we look into it from a Telia perspective, we can see that we think that in some kind of way we need to start to collect the different kind of sensors values. We need to make it in a way where you as a patient own your data, and you can share it to those you would like to share it with. When we looked into the way of the legal setup in Sweden and other European countries and try to navigate around how to interact around this, we saw that if we can provide a set where you can store a first copy of the data, and you after that can decide to share it with your doctor. And we had a long discussion with the doctors in Sweden, and then said that you are not allowed to push the data to the hospital, but you can talk to the doctors, and the doctor can ask for the data. So we set up a situation where you use the integration platform and the standardization of IH contracts to be able to support that. And we are now doing different kind of pilots and set up and hope to launch this as a concept in the beginning of next year to support as a one step. But of course, the data is the patient's, and you can take the data and leave the concept if you would like to do it to the next step. To take another service to another supplier. Because one of the most important thing is there is open interfaces, and we also support Continua as a discussion from the Nordic perspective. But I also think that we need to understand that if you go down to and we look into what's this about, it's so easy to forget the elder people, the possibility for them to take new technology. But we can see in different kind of pilots that it's a very interesting step, and we can see that a lot of them, if they get the motivation, they are really into it. And we did one test in one area. We took 300 persons together with a multipalacies and started them to educate it on using tablets and mobile phones and so on, who has not been working with it before, 85 years or older. 200 of them signed up for the course. 180 of them bought a tablet after the course. And they are talking or sending out the message. My grandchildren feels that I'm so cool now. I have a tablet. I'm into the digitalization world. I can have a Skype call to my children and so on. And of course, it all starts with the motivation. Setting up the right kind of service and the right kind of support and the ecosystem around. I think that we have a lot of activities to do around that if we would like to support the ecosystem in the way that we have the data and the possibility to use the digital services. So thanks for me. And that's a little in view from what we're doing on and what's the pictures and the scenes that we're working on the Swedish side with.
We probably have like a minute or two for a question. If there's a question or a comment from Nicholas, mostly because I want to throw the box at someone. So come on, who has a comment? I could just like go long and okay. Well, let me ask a quick question.
Yes.
So you talked about putting together that ecosystem in Sweden and presumably in Finland as well. How close are you to getting that to any kind of scale past a small pilot with those few hundred people?
I would say that we're having the discussions together with several hospitals, and we are aiming for it in the next year. And we're having, as I said, the discussions, and I hope that we will have the agreements before New Year.
Okay, so next year you're going to come back. We're just going to put them on the spot here. Next year you're going to come back to Vertical and explain how these types of pilots are going to be working at scale in Sweden?
Yes.
Great. You heard that? Lovely. Okay. Nicholas, thank you very much.
Thanks.
Okay. Next up, it's, I'm still going to get to throw the box yet. This is Carlos Jamie, got his name right there. He's Portuguese, not. And we're going to hear from Carlos. He is the head of health and medical equipment division at. He's a Portuguese guy at Samsung Electronics, a Korean company in France. That makes a lot of sense these days, international. And we're going to hear more about the ecosystem of electronic devices, which are going to be playing into some of what we just heard about from Chile. Carlos, please take it away.
Thank you. I just tried to say hello in Finland. Hyvää iltaa. Thank you. I just want to share with you the Samsung Electronics healthcare vision, but I will start by one. I'm sorry, it's not working. No.
Can you do it manually?
Next. Next. Just next, please. Yeah. The first slide is just for digital septics. Last year, we sold more mobile phones in the world than the toothbrushes. And if you have money to invest, it's probably the best way to invest in digital and probably in digital health. Who we are? Samsung Group. Next, please. We are a startup company based in Korea with $300 billion turnover and 384,000 people in the world. But what it's interesting to share with you, we have 7 companies in healthcare environment. The first one, you have your own hospitals. We have 10,000 beds in Samsung Medical Center, and we're able to use your technology inside your own hospitals. We have biological companies. We are also a provider of medicine, of medicaments, biosimilars, and we have definitely a healthcare company. I would like just to share after with you the coverage of Samsung. Next, some market data just to explain. Next, please. Just to explain where we are in mobile health market. This market it's quite a strong opportunistic market for all companies, of course. I'm quite skeptic also on this growth presented by some experts, because now we are facing some difficulty to start from POC point, some small examples to industrial health-connected projects. Next. Nevertheless, 2/3 of people are consider health as the main concern subject for life. 86% of Americans, 17% of Europeans try to find information until to meet the doctors. Just 50% of Americans try to do alone the diagnosis until to meet the doctors. The market is quite now mature for digital solution. This is in this part, this is just a French example. In France, we are facing some economical troubles. The debt of hospitals is 28.3 billion euros. Now we have to change dramatically the model of health in France. The objective of health ministry is to divide it by 2 the number of beds, and to divide it by 2 the number of days you are staying in your beds. And for this reason, the market of mobile health will accelerate in the next coming years. This is the case in France, this is the case in all Europe, and for this reason, the market growth in Europe is higher than the other continents. Next. Next. This is just another view of the global healthcare market. It's not done by Samsung, this is done by IBM, but this is just the market potential we have. In the right part, you have chronic monitors patients. On the left part, you have wellness people, but the main part of the business potential in the market is in the middle, and we have low number of companies in this market segment. Next. This is just an overview of your vision of some brands, some company in this market. On the right side, you have medical device company, as Philips, Roche, Medtronic. On the left part, you have a wellness company, as Philips also, on the Apple, High Health. On the middle part, you have small number of companies. At this time, we identified Google, because Google invests a lot, as you know, in the big data management in this market. But the objective for me is just to share your coverage. Now Samsung is able to provide wellness solution, medical device, but also data device for the main part of the market. But the main tool provided by Samsung in the market is SAMI. SAMI is a global cloud, not dedicated for Samsung, but able to agglomerate all digital information. For example, if you are one company, one startup, if you want to put your data in SAMI cloud, the time you will spend is just less than 1 hour, and you will be able to provide your data in this cloud. SAMI is already in place, and SAMI is able to agglomerate more than 10 billion devices at the same time. And this is what we are providing yet in order to not to connected device, but to organize the data able to be provided to other companies in order to manage these data. And this is what we are able to provide now. And we are already signed number of deals, agreements on SAMI. For example, on number of American hospitals, in healthcare, but also with Valeo, with Cardiff in insurance. All data are now in the SAMI. This is just what we have also. We have some medical device in your portfolio. And this is just few examples of what we are doing now. We have some French cases in people health management. We are following diabetes people at home with University Hospital in Lyon. We are also in partnership with Innovelan, is a small company in France. We are following in a big part of French territory some chronic renal failures, also some heart critical patients. And this is what we are already in place, but the main objective for us now is to switch from small projects to a large one, and this is what we are working on. The next, what will be the vision of Samsung, what we are doing now with a large hospital organization. We try to provide digital health solution from home to home, because the main difficulty we are facing, particularly in France, is the relationship between patients, private doctors and hospitals. We have no continuous communication from home to home, and this is what we are providing now. We will launch in the end of the year in open source 9 digital tools able to manage the whole relationship between patients, doctors and hospitals. Your vision of digital health is optimist, but the health, we have some bad experience in health digital solution in place. We can do good things, but we can do also bad experience. We can have a bad experience. What we are working on is to change the way of working inside the hospital. Health professionals, are they designed to disappear? This is the one question I receive sometimes. No, definitely not. Doctors will dedicate the time on face-to-face for patients. Currently, the doctors spend too much time for administrative actions. The objective of this new digital health solution is to reduce the time of administrative and to increase the time in face-to-face patient. The future of health will be not in departments. In the current hospitals organization, you have oncology department, you have radiology department, you have osteoarticular departments. In the new hospital organization, we will treat the patient as a human, as a body, in global body, not on just a neck, just a head, just a breast. This is what we are changing the organization and what we are doing in your own hospitals. The impact of this new technology for health management is strategic. Your objective and what we are doing now is to put and to give the right information at the right place for the right patient in order to do a personalized treatment. Now, we can't manage a pathology in one person that we manage in another person. We must to do, like with the digital health, we must to do individual treatment. This is what we are pushing on. The last part is just a short movie of your vision in IoT at home, also in health. Let go. Maybe, yeah. Samsung provides more than 1 billion devices per year. In 2018, 100% of your device will be connected.
Oh, golf? No. Swimming? Okay.
Don't worry, I know.
Thank you.
All right, I hope someone is going to give me the chance to throw the mic. Come on. We have any questions or comments? So I do have one for you, Carlos, which is, you're here in an accelerator, which has many small companies working with it. We're talking about building an ecosystem. Kind of sounds like Samsung is building every single part. You're building the platform, but also the devices on top. What's the role for Samsung working with other smaller companies or other technology companies to do more collaboration around this?
Samsung definitely is an integrator company. We are not able to provide all device, of course, and we are working with a local company, particularly in Europe. What we are trying to do, we try to provide a global solution to end user with local partners. This is what we are trying to do as an integrator of healthcare digital solution.
Actually, you do have a lot of partners across the board for many of these different applications, I know, especially with the SAMI watch and the SIM-band, the SAMI platform and the SIM-band watch as well.
Yeah, currently we are able to connect more than 200 different medical devices in SAMI. And this is what we try to increase in order to have the best adapted solution for the market.
All right. Anyone give me a chance to throw the box? Any questions, any comments? Come on, I'm dying to do it. I might just pick somebody up. Okay. All right, Carlos, thank you so much. We think this one's working now. Okay. Okay. Next up is Jacqueline Tong. She is the co-founder and CEO of Clio Health. Come up on the stage, Jacqueline. And she's going to be, as opposed to Samsung, which is a huge company, Clio Health is a very tiny company, just getting going. Only launched its product formally in April this year. But what she's doing is working very carefully in the world of care pathway, data decision support, and patient communication. So, Jacqueline, tell us a bit about that and tell us about your view on the market.
Thank you. Can you put that catch box here? I'm going to prop up my timer.
I will wave you as well.
Okay.
I'll hold it if you like. You can
Okay. There. No, that's good. Yeah. There we go. Perfect. Hello, everybody. It's great to be here. Actually, it's great to be back. Fun fact about me, I actually lived in Helsinki, Finland for 3 years, from 2000 to 2003. And for a good part of that time, I worked for a company called CRF Box. And I eventually got transferred to the US office, and then I never really came back except for business meetings. So today, I'm going to give you an in-the-trenches look at what it's like to work at solving problems around patient engagement. And so what I really want to spend time on is setting up what is patient engagement, first of all, and then look at some best practices for those of us in the trenches. We've been hearing from a lot of big global companies, and now you're going to hear from me. So, just back to my background about how I got into digital health in the first place. Let's take a step back to what I was doing at CRF Health in about 2002. So CRF Box, as it was called when it was founded here in Helsinki, Finland in about 1999, was based on the premise of capturing patient-reported outcomes data for transmission to pharmaceutical clinical trial databases. And their objective was really just to collect clean data. And this is an early representation of their product and looks pretty clunky. Some of you may remember what a Palm Pilot was. Some of you are far too young to even know what that weird-looking thing looks like. But I dealt with this on a day-to-day basis. And what I learned through many years of implementing these systems was that the patients and providers really benefit from the self-reporting of this information. So providers, the clinicians, nurses, doctors, they felt like they were getting more information, better information about their patients' progress. And the patients, even despite these sort of clunky interfaces, even elderly, very ill patients would tell us that, this really made me feel cool. I felt like I had something to whine to every night instead of to complain to my husband or wife. And so over the years, I started thinking about, well, maybe there's another opportunity for taking a similar concept and taking it out of the clinical research context and into helping regular clinicians and regular patients who weren't involved in clinical trials, sort out their problems and coordinate care that way. So today, I'm down in the trenches in my startup, Clio Health, and Matthew told you basically what we're working on. And today, I want to share what my peers and I have come up against and what I've learned from my peers, but also through my own experiences in building that. So first of all, what is patient engagement? It's an oft-used term. In fact, I don't know if it's new here, but in the US, in North America, it is one of the most overused, almost meaningless terms used in the healthcare industry today. There's a lot of BS around it, so I think just to set us on a good path forward, let's define what I mean by engagement here. And I just went online and looked at my online dictionary, and I think this definition here is really simple. The words about participation, involvement, sharing, that's really what we're talking about when we're getting patients involved and to participate in their health care. But of course, engagement is a two-way street, and I think the industry still has a long way to go, as illustrated in these two little cartoons. On the one hand, you have a patient that is really wanting more attention from the provider, and the provider's not really listening. On the other hand, you've got a patient who is bringing in way too much information that the provider doesn't want. I think some of the previous speakers to me raised this problem. Nicholas, in asking about sensors, is it a threat or an opportunity? And I'll say that many providers, many clinicians feel that this barrage of data is a threat because they don't know what to do with it. It's not really in context of what's meaningful in how they're going to treat that patient. But nevertheless, patient engagement is really important. And I just want to share with you the results of a study that was run a few years ago. But I'm not going to tell you what the intervention was. And that's really going to underscore, how we're going to continue on today. So there's a study run with 12,000 patients, and the results were that following this intervention, 96 of the patients were screened for cholesterol, over 77% of patients met cholesterol goals, and there was a 76% reduction in mortality. You don't need to be a clinician to know that those are really amazing results. So what was it? It wasn't a wonder drug. Actually, quite simply, it was a collaborative care program that was rolled out at Kaiser Permanente of Colorado. And through that program, it was not just about IT and tools implementation. It was about a whole process change involving how the providers, the clinicians, all interacted and collaborated and cooperated with patients using technology to get information from the patient and communicate with each other. So that's why patient engagement is really important. This is a shining example of something that was probably quite expensive to roll out. 12,000 patients, so it scaled quite well, but I'm sure that Kaiser Permanente invested a lot of money into it, which a lot of organizations are not prepared to do today. But still, there's certainly a long way to go for the rest of the world to catch up to this. And by that, I actually mean the rest of the North American healthcare system. Most don't operate like Kaiser Permanente. But the data shows us that people are really interested and willing to engage in their health. So there's a lot of positive indicators, even though we still have a long way to go. So that's really the big opportunity that we're facing. Okay, so now what? How many of you here are entrepreneurs? Okay, and then how many of you here are clinicians or work for a healthcare system? Okay, so we have more entrepreneurs here. Okay, great. So you're an entrepreneur, and you're trying to solve problems in patient engagement. What things should you be thinking about? So I'm going to take you through a few examples and best practices. in these three categories. So first is provider involvement. I've seen a lot of my peers stumble and have problems, and including my own company. But some of the issues we're going to talk about are about matching expectations, making sure there's something in it for the provider, and also addressing some basic logistical issues like onboarding. How does the patient actually get the app, or whatever it is? Patient incentives. So how do you get the patient to engage in the long term? And then finally, reducing barriers. So we're in the startup world. It's easy to get enchanted by the promise of an optimistic and bright future. But we're here in Finland, so I think there's a dose of realism here as well. But there's the hard, cold reality of healthcare. These are big organizations, typically slow to change, with really tricky clinical workflows, systems that aren't interoperable, and also user considerations. So for those of you who are entrepreneurs, it might be tough when you look over at your neighbor in your startup accelerator and see he's or she is building some app to order beer on demand and doesn't have to worry about real, serious regulatory issues or data privacy. So we'll talk about that a little bit. So first, how do we make this work for providers? So you've probably seen these screenshots before, Apple Health Kit. So the reaction when Apple Health Kit first got announced was from providers. Oh no, more data. What are we going to do with this? It doesn't make sense. And really, I think for thinking about the provider and putting yourself in the clinician's shoes, we have to think about what's the important information that's going to be actionable for the clinician. For me, as an entrepreneur and somebody who's relatively young and relatively healthy, calories burned doesn't really matter. Maybe the one thing that my doctor really does want to know is how much I'm sleeping and what my stress levels are, and maybe my blood pressure. That's what's important. So that means that there needs to be some way to filter that information out. And then for the clinician, then what's in it for him or her? There's no way we can get a clinician to be excited and to promote a new tool to a patient population if they're not getting anything out of it themselves. So we need to get low-hanging fruit. How do we show the clinician and give feedback and show that the system's working, that patient data is coming in, for example, and that they can do something with it? So when we worked with clinicians, they told us that we really want to see how our patients are doing. We want to view data in ways that we've never been able to use it before, and we want to play around with the data a little bit. And then, onboarding. This screenshot is from a patient portal that's part of the Epic EMR system. But one of the biggest problems in any kind of healthcare tool implementation is how's the patient going to get signed up? Where are they going to get signed up? If the clinician is telling them about it, are they letting the patient just go home and telling them to go to some website or the App Store to download it? So from our learnings and talking to all my peers, it's really, if the patient has to be onboarded at the clinic, don't let the patient go home without making sure they're signed up and they know what to do. In this case, it's a very complicated process. You have to get some special code, type it in, and I lost my code after 2 hours. I don't know. I put it in some pocket and it disappeared forever. And so it was another 6 months before I got on. So that's the providers. Now how about patients? How do we incentivize the patients? We're going to have better luck incentivizing the patients. Mostly, patients are going to be enthusiastic about something new, even if they are maybe not as tech savvy as you think they are. There's usually some positivism there. But first of all, I think with incentivizing patients, it's about making sure that they get better healthcare. So that really, for me, I think is what patients should be. That should be the driver for patients to get involved and use a new tool. So first of all, it's give them useful information. Even if the ultimate goal is to give them better healthcare and give them better healthcare service and make them feel like they're really participating, sometimes you need to have a few nudges to get them to engage long enough so that they'll be able to stay on for longer, so enhancing stickiness. So this is an example from Propeller Health, and they do a really nice job of using the patient-generated health data to feed back information to the patient that's useful. It's using that information, using location information to give useful coaching comments that the patient can use. Now, one comment here, though, is that you can see the font is really, really small. Clearly, their demographic is probably somebody younger, maybe a child, because it's actually quite hard to read. But there's a lot of really useful information here if somebody's dealing with asthma. Patients Like Me has been mentioned before by Nicholas, I think. But find me some friends. So patients love knowing that they're not alone. And Patients Like Me is a testament to this. They have thousands of patients on their network that share an enormous amount of information about their personal lives, but also about their healthcare. And a lot of it is not necessarily identity blinded. They share all of it out in the open. It's amazing. And so how can you bring community into your tool to keep people coming back because they're searching for relationships? And then what about other motivators like gamification? This is an example from Fitbit. They use a few techniques. One is just to give you the numbers so you can see how many steps you walked. But then they have this really cute but subtle smiley face. The smile gets bigger as you walk further, and so your goal is to get to the big happy face where I think it eventually sticks its tongue out at you, I think. It's really cute, and so those are some really nice touches. It doesn't have to be over the head badges and songs all the time. Or there's also just clean, hard, cold cash or rewards. And so Mango Health, which is a California-based company creating adherence tools, has a point system where you can trade in your points to buy stuff with some of their affiliate partners. Okay, so looks like time to start wrapping up, I guess. But the last thing I want to talk about is reducing barriers, some of those ugly realities that we definitely have to face in healthcare and can't be ignored. I go to a lot of healthcare conferences, and sometimes these things tend to get glossed over. So just a grim dose of reality here. This is what healthcare professionals, at least in the US, this is what they're logging into just about every day. This is a screenshot from Epic. And so this is their reality. It looks like 1995, and in fact, they're running Windows 95. And I kid you not, when I go into providers' offices, they are running Windows 95 with Internet Explorer 6. So that is the cold, hard reality. But added to this is a complexity that these EMR systems are very much part of the central workflow. So if you have a tool that requires a provider to log in, try to see if there are other ways to have single sign-on with the EMR provider, integrate with the EMR provider so that you can have a tab, make sure the messaging flows in and there's synchronization. All easier said than done, but ignoring it will also get you nowhere, as I have discovered, in fact. But there's a lot of things here that are sort of complicated about the workflows. Onboarding I addressed earlier. But there are some healthcare systems that are also waking up to the fact that they need to change. And here's a photograph from Atlantic Health System's sort of Health Connect centers. And they've modeled this after the Genius Bar at Apple retail stores, where they have in their hospitals a little sort of Genius Bar where people can go and inquire about different tools, can learn about them and get help in setting them up. So it's really amazing. They have a long way to go, but this is a very, very positive start and probably a good example of how patients can get onboarded. And then finally, what about usability issues? So I don't know how many of you watch this show, but this is the cast of Silicon Valley. And so one of the biggest criticisms of the whole digital health industry, and Matthew's laughing here, is because most of the people, as it turns out, developing digital health solutions, most of the time look like this. They're young, white, male, you get the idea. But the people using the solutions look more like the cast of, what is this, the Exotic Marigold Hotel, so Judi Dench and family. So what do you do? I'm not so young, in fact, but we still run into issues, and our designer ran into a really interesting problem where we ran some usability tests, and this is the home page. Our plus 65 population just stopped dead when we asked them to go beyond the home page. They didn't know where to find the menu. So that hamburger bar that most of us who use digital or use mobile devices know, those three horizontal lines, that's where you go. That's where you get the menu. So we had to change things. We had to actually write menu. And I think we're starting to see more digital health solutions actually employ this, put menu somewhere. The small things can matter. But some other companies will really take the audience to heart and build the entire product from the ground up, bearing into consideration the ergonomic issues faced by an aging population. So depending on who your audience is, depending how your product is going to be used, can emphasize the fact of making sure you get out in the field and know who your audience. It's really easy to get insular and then just internally test things among your 20 or maybe even 30 or even 40-something peers, but that's not really who we're serving. So, just to wrap up and summarize, we talked about making sure that providers are involved, matching expectations to what data they need, and so on, making sure that there's smooth onboarding processes. How can we incent patients through rewards and giving feedback to them? And finally, what are the cold, hard realities that we have to address and keep our eyes open to? So there's a long way to go, but this is really just the beginning. It's a very exciting time in digital health, and there's a lot to be done in patient engagement. I really truly feel that this is where a lot of difference is going to be made. And not too long from now, I hope that healthcare really looks like this, where patients will be able to self-manage from home, and they'll get the support from clinicians when and whenever they need. Thanks.
Nice job, Jacqueline. So, again, I still have the thing to toss. So I'm still looking if everyone has any questions. We had a lot there about the different ways that you have to consider how any digital health or new technology solution has to be integrated in the healthcare system and the different audiences you're thinking about there. So when you've been building your own system, I still have the option of tossing this to somebody else before I ask a question.
Just throw it, somebody will catch it.
Yeah, so
they'll have to.
The next go, I will just be tossing it down there. When you've been building your own system, working with your own players on this, give me some sense, about the difference between the 1995, the Windows 95 Epic system running on, Internet Explorer 6 or what have you, and what you're trying to develop. For that integration piece, what are some of the struggles and challenges that you've been facing?
Well, that Windows 95 and IE6, it's real. We went in to implement one of our pilots, and we have, of course, as any smart SaaS cloud-based startup will do, we run analytics on what kind of browsers people are using. And 35% of our users were accessing our system from Internet Explorer 6 or 7. We're not testing on it. We can't even install IE6 on our own computers. So, those are things that you just keep on getting surprised at, but you really shouldn't be. And that's why I'm sharing that with you now, so you don't go out and make the same mistakes. Hopefully in Finland, things are a little bit better, but in the US...
So what do you actually do if you can't test on that? Do you have to go into their
system? We go into their system where we have to set up, we go on eBay and buy an old machine and set up Windows 95, set up a test environment, or be realistic and know that you have to support in the short term and put a certain amount of effort into making sure that things work for the next 2 years, knowing that in 2 years, maybe nobody's going to be using Windows 95 anymore. So it's a balancing act, but you have to deal with the reality.
All right. Great stuff. Well, I'm going to throw this into the audience anyway. Oh, so someone got it? Right. I had someone was trying to grab a question there.
Jackie, I have a question for you.
Sure.
For the entrepreneurs in here, I'm sure they're curious. What is Kilo Health going to be in 5 years? What's your goal? What's your vision?
So Clio Health, well, we are operating in the care coordination space, and so we work with healthcare providers directly, but we're also realizing that our solution is actually part of a much bigger picture and much better system that involves, care coordination, content, automated feedback, predictive analytics, and so, but we can't build it all. And so I think really where we're seeing things going is becoming part of these broader ecosystems that I think all of the larger companies talked about, and integrating more closely with those ecosystems, but also with the EHRs out there. You sort of have to do that to become seamless and be an integral part of the entire healthcare system. So, and that 5 years goes pretty quickly. Healthcare doesn't move all that quickly. And so I think in 5 years, if we're integrated with all those parties, I think we're going to be in great shape.
I have one more question on
Yes.
that. Have you
Okay,
started
sure.
working with, earlier was mentioned the whole smart on fire and the fire
Yeah.
approach, and getting data out of those systems and putting it into your application, back to the data and application idea rather than having any closed EMR. How's that going so far for you?
So the FHIR standard is really exciting, and there are some emerging players, so peers of ours that are developing layers that use FHIR to translate the data coming out of existing EMR systems. Some of the more progressive EMR companies are already working on FHIR or sort of JSON frameworks so that we can pass that data back and forth. But right now, it's really about just pulling the data from the medical record so that we can generate the appropriate care plan for patients rather than pushing our data back in.
Is that going to make stuff faster than 5 years? Are you going to be able to have some good results within a year?
Yes, I mean, it's not going to take 5 years to do in one integration, but to get all the major players on side, the population health analytics systems, the predictive analytics systems, the care management systems, all integrated. That's going to take, I think, 5 years is pretty ambitious, actually.
That's actually quite optimistic.
Yeah, I think so.
Okay, thanks a lot, Jacqueline.
Great, thank you.
All right. Next up is, and we now have, we've now done the bulk of people discussing. Ooh, we have exciting security alert. Should probably get rid of that. We've done that on the bulk of people who are discussing actual applications in the ecosystem, and now we're going to talk much more about the overall environment for generating a new health ecosystem and new technology development. First, we're going to start with someone from Boston in the US and then move after that to two local players. But first up is Lewis Barros from LB Ventures and MIT. He's going to be talking about the pillars of building a life sciences health innovation system. And I understand in Lewis's spelling of the word pillars, there are 5 A's. Is that right? So Lewis, please.
Great. Thank you, Matt. Thank you, and good afternoon. This is actually my very first time to Finland, but I have 2 connections to the Nordic region. One of them is that the goalie for the Boston Bruins is from here, Tuukka Rask, so you probably know who he is. And I got to meet him at Lake Winnipesaukee this summer. I have a picture that I took, and I can show it actually at the end. And also, my very first startup as an entrepreneur was a Swedish bioinformatics company right out of business school. It was a company that was in bioinformatics field, and it became a very successful company. It was actually acquired. I was the 3rd employee of that company. And at the time, the company had 3 employees and about $200,000, and eventually got sold and had a very successful exit. So with that introduction, my goal today is to talk to you about the 5 A's of how to build an innovation ecosystem. And fortunately for me, I've had a lot of experience in this, myself and the teams that I've been on and the teams that I've led. And what I hope to share with you is to be inspirational, because I think from what I can see both here, and I've spent time in the other parts of the Nordic, I've been spending a lot of time in the Mediterranean part of Europe, particularly in Portugal, and also recently in Mexico and West Africa. So in all those countries that we serve, we take the core competencies of those countries, and we transform it into a functioning ecosystem. And actually, based on what I see here today, I was in Turku yesterday, I do believe that you have the kernel and the basis to do something very significant, and I hope after this talk you'll agree with me. So the 5 A's, and I'll put them there. So I think the first thing you have to do is analyze your ecosystem and have a vision of who you want to be. So you first have to diagnose where you are today and who's your inspirational country. And we saw some great examples earlier, such as Israel being a startup nation, and there's many examples of who you can be. That's very significant and important. The second one is ascertaining your core competence. In every ecosystem, there's something you do extremely well and very different from the rest of the world. I've spent little time here, and I can tell you that anything related to healthcare IT, anything to do with a legacy that has mobile technology based on the Nokia alumni here, you have something special in that whole intersection of health IT as it relates to telemedicine. That's one area, and you have many others. And then the ecosystem has to function because each key player has very different incentives to participate. And one of the things that we always look at is how is each player incentivized? And the key three actors I'm going to talk about mostly will be university institutions, industry, and investors. They all care about different things. Investors care about liquidity. If they get to get in, they have to get out. Universities will care about research and translation and prototyping. And industry care about pipeline, particularly in the healthcare industry. They're looking at pipeline. In this particular setting, looking for better communications and direct-to-consumer marketing, something they're very novel at, something they're not used to, and in many countries, something that's really prohibited or even difficult because of the nature of laws. In the United States, for example, HIPAA laws. Experience is important. You cannot substitute for experience. And I'm a big fan to saying experiences that not only come from people who have done startups, large corporations, some of them you've seen here today, Samsung, Philips, many healthcare organizations are very entrepreneurial in nature. In my particular career, I started at Johnson & Johnson, and I can't tell you that that company is as entrepreneurial today as it was then, as any startup that it is today. So I know that big corporations have very experienced people, so experienced people have to be in the ecosystem to help mentor, to help advise. It's a very critical component. And then finally, there's a notion of advocacy and public policy. I actually met this group when they came as part of a roadshow in Boston, and it was part of a public policy mission. So trade missions, the rest of the world has to know what you're good at. You have to promote it. You have to promote it here locally. You have to talk to the leading actors here, the leading people in government, people in public policy, to create policies that make things like this work, that makes programs such as vertical sustainable for the long term. And also, you have to have that publicity and promotional image throughout the world and the nations that you're trying to collaborate with. So let me first just go quickly into LB Ventures, what we do. We actually just have a simple formula, management consulting on one piece. We have a particular competence in doing what we call private accelerators and accelerators that actually leverage international accelerators and give them an ecosystem immersion in the United States, particularly in Boston. We do some work in Silicon Valley as well, and there's other ecosystems such as New York that we lightly touch. And on a second piece, we tend to work with venture capital funds, particularly in emerging countries who are doing it for the first time, and take what's called a classic venture partner role, where we work with a subset of portfolio companies that we think has global potential. And in that particular instance, we take them to realize their global potential in many different interventions. And those interventions can include from getting additional equity for the companies, getting additional non-dilutive financing, to putting a non-executive chairman or non-executive directors on the board, and so forth. And so if I'll give you an example, so this is a program called K-Teams that's run in Cambridge. It was incubated at MIT. We have had it for about 4 years now in 10 countries. What we typically do is work with international startups. It could come from programs such as this one. And then they want to go ahead and elevate their visibility in a global scale. And typically we look at this ecosystem, particularly strong in life sciences and health IT as well as medtech. And you can see over the years, that we've had a significant amount of growth and traction in terms of the countries that we serve. We started out really just working with Portugal because I was the anchor client. But over the years now, we have now worked with about 8 different countries. And this year, we think we'll probably double that. We work particularly in the UK, Italy. We also have work in Eastern Europe, particularly in Hungary and Bulgaria. And also have done some work in Latin America. And this is a program that's available, it's active, it's got a website, so you're welcome to take a look at it and see if some startups you're working at could benefit from this. We'd love to have you in Boston. This is sort of my background, so for good or for bad, I've been in this for a long time. Started out my career in corporate venturing, got into university venturing, both as a student, as an alumni at MIT. That's the 2 companies I was involved with as a startup. I can't get this pointer to work. Is this? There you go. For whatever reason, it's not. It doesn't? Okay. Sorry about that. So what you see, Spotfire and Softtricity, those were 2 startups I was involved with early on. Both of them were successful. I have one that wasn't quite so successful. There was no room on the slides for it, so I didn't put it there. And so just to take it to the present, this is some of the client work now. So you can see in the corporate and VC angel-backed, ranging from a Japan initiative oncology, always to local robotics technologies in Cambridge. The university side, as I mentioned, is a large-scale program headed by MIT Portugal that we served as program managers for. And international venture capital, 2 areas, Portugal Ventures, which is an $800 million fund out of Portugal, and Beaumont Capital, which is a $600 million family office out of Mexico City. And then a lot of work with the United States government, particularly with the SBIR program, which is called the Small Business Innovation Research. It's a $2.3 billion program that creates a lot of companies. So we try to get perspectives from the government side, international universities, and corporate. So at any angle that innovation comes from, we're ready to work with you and make you successful. So let me just talk about the pillar of this presentation, which is probably the flagship program that I was involved with was this $1 billion initiative out of the Commonwealth of Massachusetts to drive life sciences. And the way it was designed is that in any ecosystem, there's always interventions that are necessary for what I would call imperfections or market acceleration. In this particular case, it was designed as a 10-year, $1 billion initiative looking at 3 different programs. One of them was around infrastructure. So for example, we've created a shared experimental infrastructure for biotech startups, a company called Lab Central. We were the first investors in a major accelerator program, which is now the largest accelerator in the world, which is called Mass Challenge. And we also have been involved with over 1.5 million square feet of development in this particular area. And the tax incentive side, it's really, so this was clever. We went to the Department of Revenue and we told them is that startups don't make profits, so they can't pay taxes, but they generate jobs and they pay payroll taxes. So we created 9 different tax codes in a state tax code to enable young companies to get credits based on paying payroll taxes, not so much paying on income taxes, which was pretty clever. So it's 9 different codes that were created for that, and also extended the period of years that companies were on long life cycle development up to 15 years can carry their losses into a tax credit as well. And then finally, on the small business side, a lot of that was involved with helping young companies through what you all know as the value of death. A lot of it was really designed around that. So how do you go about doing innovation analysis? So first thing you have to do is taking a look at the sites of innovation that you want to model or look at. So when we looked at Kendall Square at the time, we did compare ourselves to Palo Alto, Berkeley, California, San Francisco, and I wish the pointer had worked so I could point to it, but what's interesting is you have to look at the concentration of firms in terms, if you add the number of IT firms plus the number of science firms, and you look at the distinguished pedigrees that your academic medical centers have in your institutions, particularly your faculty, your professors, your scientists, you start to get a raw score, and this was developed by Boston Consulting Group. And you can see that if you look at innovation strength on the far right, it's no secret that some of these hubs are very successful. You can see that Kendall Square ranks pretty high. And what makes it special is the density. So it's equal, probably a little bit behind Silicon Valley in terms of pure prowess, but on a per capita basis, it performs pretty well. So let me just give you an analysis of how we did it in Portugal. The way we looked at it, we recognized right away that Portugal is right in the middle of the European countries in terms of the key conditions, resources, processes, and results required for innovation success and venture capital. So we have an entire program around that. I won't go into the detail, but that's the very first thing we did was take a snapshot. We did the same thing in Mexico. We compared Mexico against its leading peers, Brazil, Chile, Colombia, and Peru. Across the left, what you'll see, the dark circles, the filled circles is what's important. So if it's dark, it's filled, it's great. And you can see what high potential here, if you look at the very last one on the left, which is private equity penetration, you can see that Mexico is tremendously underperforming the rest of its peer countries in terms of private equity, which spells opportunity. And that's why we're there. So we launched a venture capital academy that is taught in the entire country. It's been taught 3 times, Mexico City, also on Culiacan, and also Monterrey. And the idea that education around this instrument of investment will actually elevate the entrepreneurs in the system to develop companies that are venture capital eligible. So we talked about the analysis. The next is ascertaining your core competence. I think really here, I'm just going to go quickly, it's a classic marketing analysis. You look at your 4 Ps and 3 Cs. What are your strengths? You know, who's your customer, what's your core competence, who's your competition, and then you look at all the factors about, you know, the distribution of the image, you know, what kind of cost structure exists in the ecosystem for space, for entrepreneurship, and et cetera. So all these are important, and I mentioned advocacy and best practices. And the other thing is I really think is important, you have to ask yourself, who's your customer? Who is it that you're trying to serve? And one of the things that we did really well in Massachusetts, we knew that we were behind the scenes and re-engineering the way the pharmaceutical industry looked at the future. So if you looked at the pharmaceutical industry, the trends that are transforming it, a lot of that has to do with spiraling R&D costs. You know, if you look at proliferation and distribution of healthcare outcomes, a lot of that has to do with big data and consumer health. If you look at the demand for safety and post-marketing surveillance, that has to do with reimbursement and economics. So under that context, we know what that meant is that the R&D risk profile for pharmaceutical companies are going to shift to really supporting validation so they can get a lot more companies and products in the phase 2B area. And so if you were successful in doing that, what would happen is that you would create an ecosystem that the industry would be interested in being in. And that's exactly what we did. We created a lot of intellectual property programs that universities could innovate so that the federal government, such as National Institutes of Health, could fund. And that created intellectual property, creates patents. And that creates product, that creates pipeline, it attracts industry. So to talk about the next part is attracting ecosystem. So this is what it looks like now, today. Fast forward, when we entered the program, this is like in 1999, I believe it was, 98, we were not considered the #1 life sciences ecosystem. As a matter of fact, out of the top 15 pharma, only 3 were present. Today, all 15 are there. If you look at the med tech industry, again, all the companies are there today. They were not there then. So this has a little bit to do with it. So if you look at what happened moving forward, the Milken Institute, Jones Lang LaSalle, and Richards Barry Joyce, all of them have recognized it now as the #1 life science ecosystem. And it has, of course, a world-class medical institution. So what's more important is what's behind this. How did this happen? And that's what I want to show you. Not so much, I want to show you the result, but how did this happen? Well, first, there's a density of colleges and universities. There's 74 colleges and universities in that area. So those colleges and universities pump a tremendous amount of money into R&D and create a tremendous amount of intellectual property. So about $1.5 billion in R&D, 264 patents. And then if you look at some of the institutions that are there, so MIT is one of them. MIT, there was a study that was done that said if MIT's inventions and companies created became a single country in terms of GDP, how would it rank? It ranked number 11th in the world behind Italy. So there's a tremendous amount of innovation. This is driven by the ecosystem there, and the university has so many programs for creating companies. And some of the companies you recognize here, such as Bose, iRobot, Raytheon, Dropbox, all were created there. And some of the things that are important in terms of mentioning is that there's a lot of effort in online learning. The school itself has a tremendous amount of faculty prowess in terms of Nobel Prize winners and who are current faculty members. And you also can see it's a tremendously international school. So all this, the Kaufman study showed that MIT graduates have founded 25,800 active companies, which employ 3.3 million people, annual sales of $2 trillion, and like I mentioned, 11th largest economy in the world. So it's important, whenever you have a great university, those metrics don't have to match. They just have to do what they need to do, which is education of the best talented minds and prolific research. So this is the magic behind all of this. This is the entrepreneurship ecosystem. And again, I apologize for the pointer not working, but what to pay attention again is the dark circles and the stars. There's a tremendous amount of intervention within the university that occurs to help this innovation happen. So on the far left, technology licensing is important. So there's a whole technology licensing process. If you look over, you see the Deshpande Center and the Trust Center. Those are 2 different programs, one to enable faculty entrepreneurship, the other one enables student entrepreneurship. If you look at VMS, you saw Bose earlier, so the former president and CEO of Bose Corporation runs a program called the Venture Mentoring Service, or VMS, and that's designed to help mentor young companies. It's all volunteer, it's experienced executives to help companies be successful. And that mentoring model now is actually replicated in about 50 countries around the world. And then so, where do we engage internationally? You can see that this is now being replicated all over the world. Japan, France, United Kingdom, Arab Emirates. And I'm going to give you a specific example in Portugal, which we were directly involved with. And this is a comprehensive innovation network. So we took those pillars, brought them into Portugal. The program is about 8 years old now. And you can see that it's all over the country of Portugal, 6 universities, but you have the education, you have the research, you have the academic affiliates, and you have industry involved. And if you look at the ecosystem that's been created, you can see, again, the education and training ecosystem in terms of the faculty is there. On the far right bottom, you'll see the Innovation and Entrepreneurship Program. There's a venture competition that's been created that gives €1 million in prizes. And that is supported by Portugal's largest bank called Caixa Capital. And that program has generated 60 new startups. Those startups have raised over €27 million outside of the program funding, and they have created well over 350 jobs. And now it's in its 5th edition. And of course, industries are heavily engaged. And this is ongoing in Portugal. So the next step, of course, is a relationship we have with the newly formed venture capital fund. It's an $800 million fund or 600 million euros. I guess that's less now because euros has gone down. But at the time I used to say 120. I have to recalculate what that is. And so again, you quickly look at the inefficiencies in the ecosystem. So we quickly know, let me just go back. So first of all, you have to stimulate deal flow because it's new. So you have to work with universities, work with incubators on deal flow, and to package deal flow in an appropriate way that it can be analyzed by reviewers. Secondly, then you have to use a whole network of entrepreneurs and advisors to review the deal flow. And then you set up outbound hubs. So there's a hub that is located in San Francisco and Boston. There's one in Berlin. And there's one going to be in Shanghai. There's sort of an affiliate operation in London. And that's because Portugal is a small country, and you have to look at a global market. And then finally is attracting capital. So there's an angel network incentive program that's created as well. So if, I talked about Mexico earlier, I didn't want to leave Harvard out of the equation because Harvard is very strong also in Cambridge. And Harvard, again, same type of program. They have at Harvard iLab. Some significant companies such as Facebook and Staples have been created there as well. So let me just go quickly through some of the things that are key in the ecosystem. So first, federal funding. NIH funding, you can see again, Massachusetts is #1 per capita. 8 out of the top 14 NIH-funded institutions come from Massachusetts. That's very significant. Patents issued per capita, second only to San Jose. And this creates patents and intellectual property creates products. Then you have 5.5% of the global pipeline, 11% of the US pipeline. But what's significant, you're hitting unmet medical needs such as neuroscience, oncology, you're hitting cardiovascular disease, anti-infectives. It's important to be relevant. It's important to hit the needs that the patients have where you're solving unmet medical needs. And here's the ecosystem of Boston. You have investors, you have publications, you have trade associations, you have service providers, you have corporate R&D labs, and we talked about the educational institutions. And this is what it looks like. So all these institutions exist. They didn't exist 15 years ago, and you can make those institutions exist here as well. And then if you look at the impact in terms of economic development, you'll see that some of the major pharma are here, from Genzyme to AbbVie to Pfizer. As I mentioned, 15, the top 20 are there present. Same thing in medical device as well. You see some of the big players, and you can see it's also a major contributor to economic development in terms of total workers and jobs, 21,000 workers, 80,000 jobs. And liquidity, so investors care about liquidity. So the fact that there's been a tremendous amount of liquidity in IPOs, that's a good thing because investors can actually partake in this ecosystem as well. And there are incentives put in there, whether they're capital gains incentives, credits for angels to get involved. So this doesn't happen by accident. Those policies matter. And if you look at the investment in biotech companies, this is a record number in 2014 where there was 1.8 billion invested, and that's by far the largest anywhere in the world. And then if you look at the seed capital, there's a lot of complaints there's never seed capital. We don't get, all the seed capital we need, but I think it's growing, and I think it's the case for most places in the world. And those are some of the IPOs. So quickly, just want to go through the pillars. First, you now analyze the vision of what you want to be like. Secondly, ascertain the core competence. Thirdly, attract the ecosystem with incentives. Every single actor in the ecosystem must have an incentive. That's important. And the advising and mentoring, acknowledging best practices, and also sharing with experienced alumni and experienced executives. So as I mentioned, K-Teams is something in Boston that looks at bringing all this crystallized to a small group of international companies. And the program is designed to help companies finance, sell, manage, and connect, as well as explore the ecosystem. And as I mentioned, it's a turnkey program. It's been incubated at MIT. It is now a private effort, so we were able to successfully spin it out. And now it's going to be offered more broadly, other than just institutions that are contracted with MIT. And so again, I put there the key pillars, and I think that's going to wrap my comments, other than the fact that I think advocacy is important. So it's important we have both the Biotech Council and the Mass Medical Council, and they spend a lot of time at the federal and state level advocating around the regulatory side, advocating around state legislation, and any key areas of reimbursement and things to do with patient advocacy and so forth. So that concludes my remarks. And I'd like to thank you for your time this afternoon, and I hope that I didn't go too fast, but I try to cover a lot to give you a flavor of what goes on in a hub that I think you can emulate. A population of Massachusetts is not too much bigger. It's about 6.4 million. So I think you can probably do this as good as we can. So good luck.
Okay, give me the chance to throw the mic one more time. Any more questions? I think, you know, there's a huge amount of data from Lewis there, a huge amount of information about, do I see someone way at the back? Pekka, I think you are looking like you need to ask a question. Part of the throw? No? Well, okay. Hang on, there it is. Good. It's very dangerous in this new mic.
I see a
but I
question.
mean, I think my takeaway is that none of that happened by accident.
That's correct.
You talk about the free market and innovation, but there was a lot of design at every stage all the way through and all the stuff you talked about.
Yeah.
A question?
Thank you very much for your presentation. I've been to Boston myself a couple of times, and when listening to you, it seems like Kendall Square and Harvard Square are really far away from each other, but in reality, they're very close. But how about, are there any joint programs between these two big institutions, or are they just fair competitors?
It's a good question. I mean, I think even across the academic disciplines, there's always cross-registration and joint programs. There was a program called the Biomedical Enterprise Program, which was around life sciences. That was a joint effort between the Health Science and Technology Program and the Public Policy Program at Harvard. So I think there's more collaboration than anything else. I think you see the students coexist a lot, and a lot of the startups are founded usually by both. So my sense, both as a student, as an alumni, and also working inside the institution for a period of time, is that it is more about collaboration and than anything else. Like you said, they're pretty close to each other. They're divided by Central Square. So there's Kendall Square, Central's in the middle, then Harvard Square. So it's 2 train stops away. But there's certainly, I think, there's a healthy competition, which I think is good. I think both, for example, Harvard has something called iLab. Most of the innovation at MIT happens at probably the Deshpande Center, the Trust Center. Then we have the Cambridge Innovation Center, which is neutral, but it's located on the campus of Sloan. But I think in general, there's a good amount of healthy competition. But I think what people really want is both Kendall Square. And there's another part of Boston that's subtle in the presentation, which is Longwood Medical. Also, all the hospitals in the Longwood Medical area, and those are primarily Harvard teaching institutions, and they have a big role to play. The institutions you would know, such as Dana-Farber Cancer Institute, Joslin Diabetes Center. These are world-class institutes that do a lot around oncology and diabetes innovation, and they certainly are very important, and they're exclusively part of Harvard.
All right. Thank you very much.
Okay.
Okay, so next up, we're going to have 2 briefer presentations. They've been 20 minutes once. We have the two 10-minute presentations just to close up. The first one is, and these are from people in the ecosystem building this out in Finland right now. The first one is Antti Kivelä, hope I got your name anywhere close to right, Antti, who is from Sitra and the Digital Health Hub in Finland, talking about building a national operator for health and well-being data.
Okay, thank you. So it has been a long day. A couple of words about Sitra. I don't know if you know Sitra. Sitra is the Finnish innovation funding agency, and we have been doing in this health care space about 10 to 15 years, and I explain what we are doing. This is a very basic question about the well-being data. So everybody is speaking about the data, but healthcare data is if we are speaking about the well-being, it's only 10% of how we feel us. Then we have environment and social factors. There's people from TeliaSonera. Even using a phone is healthcare data, because in some contexts you can find that if I'm using telephone every minute and so, you need some kind of medicine because you are too hectic to use that. And there's this kind of. And also the traveling data is the healthcare data. It's if you have been in Liberia and you have fever, it's also the what you have a connection to health and traveling. And according to this study, the genetics it's about 30% of your well-being. As there's Ilkka Kunnamo's presentation about that. And all these things that we are using and collecting information about our behavior and our lifestyle. We have apps, we have trackers and so on. But what we are doing in Finland, we are very good collectors in Finland. We have started the system to collect information in 1628. There was a Bishop Rotfish in Turku who decided that we must collect the data. And we are very good collectors. We have been collecting data since then, about 400 years. And we have put all that data in different places, inside the rock, in the servers. There's enough data today. But how we utilize that? Because there's a speakers here to say that we would like to have that data, somebody likes to have data, and we have already in this nation, we have collected enough data. All this data, we have, as a Sitra, we have been involved in this business. There in the healthcare, we were in 15 years ago, we make a first step to the national-wide electrical health record system, to Kanta, which is now in place. That was our initiative in taking that account. There's also, in behavior and lifestyle, we have a national-wide personal health record system. We have established the Taltioni system, but there is others, and now the government had decided that there's a nationwide personal health record system. About the genetics, we were involved in that process in about half a year ago. There was a Finnish new genomic strategy, which we did with the ministry. So we have all that data now available and collected. And how we utilize this 400 years collecting data is that we need this information. I go this because there's. So what we are doing as a Sitra today, in this, there's not that in data creation there is a lot of data available. What we are now doing in Finland, we have just started quite a big project. Together with the ministry, we are going to change about 50 to 20 laws. And so that we are making this one-stop place where you can have all that data available for the development, so that this ecosystem and partner network, you can utilize that data, but you need the license from the individual person to use that data. That is very crucial thing that we also think that the customer must see who is using his or her data. And as Ilkka Kunnamo mentioned, in 18 of this month, next week, we are taking in use this X-Road system, which are now in use in Estonia, and we are launching that, and that allows also to show all the people who is using their data. So all those components are there, and now we are building this. We call that national operator, service operator. We are going to give the new name for this operator in next week, but I don't give the name now. But anyhow, this is the idea that in the worldwide basics, you can have in very near future all that data in use in one stop, one company, or what we are creating here, and one contract, one license, and you get all that data what you need, genetic data, behavior data, all the patient data, if you have the license from the customer or the patient to use that data. That is our aim, and that we are doing. I think that this kind of combining these different data is unique in the worldwide basics, and if it's available and all the laws are, that's you can use, and the laws are ready for that. Okay, that's all. Because they are waiting to drinks.
All right. Okay, so excellent. I still have a chance to throw this. Any questions about the? That was, I think, both a great overview and explanation, but also, an interesting question about how you're putting that together and what uses can be able to be made of that data set. So give me a sense about what you think small companies or others in the ecosystem will be able to do with that kind of data set.
I think that many companies are now, they are focusing that how they get the customer data. But if the data is already available, why to bother about collecting data? Just start to using that data.
And do you think it's an international component of this? Do you think other? Yeah. I think there'll be a lot of interest in that. Yeah. We'll promote that. I think when you're dealing with the ecosystem part that Lewis was talking about, promoting the international ability of that data will be a big part. All right. Any last questions? A chance to throw the box around. I can't believe no one wants me to do that. All right. So now we're down to the very last presentation. Thanks a lot. This is Maria Lena. Rinkeva. I hope I got even close to your name there, Marina. She is the business director of the City of Helsinki and the chairman of Health Capital Helsinki. So she's going to explain why, in terms of ecosystems, Helsinki is going to be the place.
Exactly. I'm going to tell you why in hell all of you are here today, and why you should and your company should be here also in the future. And this is not an easy task for me, as I'm the last one standing here between you and the drinks, and also I'm speaking after Luis who has been telling us about what's been done in Boston and in MIT. So, but I will definitely tell you why in hell. Well, all of you know what's been going on in Finland. We can call ourselves the small giant of health tech, and the value of Finnish health technology export is growing very rapidly, and it's the most significant high-tech segment in the Finnish industry at the moment. So it's almost like the half of our export in high-tech field, and it's really something that we can all sort of make it use of this potential. So why in Helsinki? What is the ecosystem in Helsinki? I have to say that it's not, we have the ingredients, but we have to really build it. We have several companies now here employing 3,500 talents, generating a turnover of 1.2 billion yearly. And we have very many life science talents and graduates yearly. We have Aalto University, Helsinki University, other also higher education institutes who are really offering very high quality programs and very high quality research in life sciences. For example, Helsinki University Medical School is ranked among the 50 best in the world. So that gives us a very good opportunity to really build this ecosystem. So thinking about the closeness, we think about how close, for example, Meilahti campus is here from Otaniemi. They are very close. You can bicycle between the campuses, and then we take the Kumpula and Viki campuses, which are also putting in the map. They are very close. And if we think about the sort of the proximity of these campuses and the sort of the potential in this area, putting these all the capacity in these campuses together, that is really building the ecosystem. Oh, there are some problem with the presentation. I can see that there are letters sort of jumping, but anyway, I have a very easy job. My job in the city of Helsinki is only make sure that our business environment is such that we can create jobs. So what does that has to do, what we are talking about this? You can sort of have this big picture in any area. But here in the health tech and life science, we can see the big change also in this area from closed innovation to open innovation. We can see the change from big companies taking startups to a very close to their what they are doing and how they are innovating or how they are planning to innovate. So the big change is happening also in this area, which has happened earlier in the other areas. We have also within the city of Helsinki, we are spending half of our budget in healthcare and social services, which is about 2 billion euros yearly. So we have a great interest in how this money is spent and what we can do in order to make it more efficient. Even after the government decisions last week, we are still very much interested in how the money is spent. Of course, the potential here is how do we enhance cross-disciplinary research and collaboration between industry and healthcare to make really these innovations happen. And one of the examples that City of Helsinki just did actually last week together with the pharmaceutical industry is that we launched this initiative that we will open up our healthcare centers for clinical research. And this is really a huge step forward for this collaboration. So how do we actually plan to do this or build this ecosystem? I really like the 5 A's that we heard from Luis. And we have been doing this really now doing the analysis part actually. And then of course we will continue with these other four A's, but really bringing these to all the players together. For example, this event is a very good example of that. And the activities that we are actually now planning to do is we will open an innovation space in Meilahti, probably in Biomedicum or in that area anyway. We will provide better services for startups and SMEs and bringing also big companies together. Clear roles and rules for collaboration. This is very important that we have clear rules. For example, that we have a very easy access to research, which means that, for example, the master agreements has to be sort of like a universal for that. There shouldn't be a different kind of agreements for the hospital and for the university, but they should be universal one agreement. And of course, really improve processes from research to international business. And the Health Capital Helsinki is about really bringing all the players together. We have, like I already said, the universities, but also other players. And what is my goal is that in next year's time, we will have this slide will be full of different kind of players. So what we can do is really be like a farmer, create conditions, and definitely hell yeah.
Thanks so much. So, just before I might kind of wrap up, a couple of things. I mean, I think so. There were a wonderful series of presentations there. Great, well put together by Kenneth and Pekka and the whole team here. Can I give it up? Can we give it up to them because these guys worked really hard, put together a great program. And without summarizing all of them, we went from the very specific about how, are the problems we're facing in healthcare between established legacy systems, putting together new types of technology, and building that sort of interface between them, as well as then thinking about how do you build the ecosystems between large companies, innovators, governments, cities, hospitals, universities, investors, and all the rest. And you've got the lessons from Boston, what's going on here, and then, of course, the role of the large companies as well, like Philips and Samsung. So I think a lot of variety there, and I'm very, very exciting. So couple of things to mention on the Slush. I see a startup presenting thing behind me. Just some activities that are going to be on Slush that I would recommend to you. If you want to know more about that World Bank initiative, the IFC initiative, that's on the engine room stage tomorrow morning at 12:30 for about half an hour. You're going to hear more about the World Bank and the initiative, the Tech Emerge initiative. You'll also see that at techemerge.org. On Thursday at 11:30 on the... I lied to you? No, I didn't. Yes, Thursday at 11:30 on the green stage. There's the future of healthcare. You'll see Steve Krein, who was here earlier from Startup Healthcare. You'll see me. You'll see Yanni I can remember pronouncing his name, Yanni Alholonana from Nuna, and Oliver Mika, I think, from IBM on the future of healthcare. And immediately after that is a session about wearable healthcare, and then immediately after that about personalized medicine. So a lot about healthcare on Thursday. And then finally, last and absolutely definitely not least, in fact, probably the most important on Thursday, back on the engine room stage, and you should have one of these, if you haven't already. This is the Spa Health, the non-profit, headed up by the same folks who work at Vertical here, and they are presenting a whole bunch of different startups. That is between 4:30 and 6 o'clock, health and wellness networking by Health Spa in the engine room, part of Slush. So if you care about health technology, healthcare, there's 3 things to see, and I'm sure most of you will be at Slush over the next couple of days. And with that, I think I'm done. I want to thank you very much and hand it back to Kenneth.
Thank you very much, Matthew, and thank you very much to our great speakers. At least for me, this was very inspirational to hear about all this stuff, not only what we're doing here in Finland, which we so often talk about, but actually hear a little bit wider, a little bit broader about what's going on in this field. So, the end game. I guess I'm the last one now, actually the last one between you and the food, which is being served for you. And I really wish you had a really great time at Vertical, and stick around and network, and for all of you there at home, that you have also enjoyed it very much. My name is Kenneth Salunius. I'm from Vertical Accelerator. It was great to have you here. Thank you.